All right, let's talk about sepsis. It's a condition that completely changes the game, especially when it comes to how our patient's body has handled drugs. Now, if you're an anesthesia trainee, you know this is a classic exam topic, but it's so much more than that. Getting this right is absolutely crucial for managing some of the sickest patients you will ever look after. So let's crack this code together.
So we're going to approach this just like you would a final FRCA question. We'll break it down piece by piece. And by doing that, you'll see not just the answers, but how all the underlying physiology connects, which is exactly what the examiners are looking for.
First up, part 1, the definition. I know, it sounds super basic, but trust me, getting this definition right is worth 2 easy marks in an exam, and you've got to be precise.
And here it is. This is the definition from the UK Sepsis Trust, and it's the one you need to have locked in. Notice there are 2 key parts here. First, it's an overwhelming response to an infection. The body's reaction itself is the problem. And second, it's all about the consequences, the tissue damage and organ failure. You need both of those components in your answer to get full credit.
Okay, so if sepsis causes organ damage, the next logical question is, well, how? This is where we get into the nitty-gritty, the devastating chain of events that unfolds at a cellular level. It all kicks off with this massive inflammatory response. You've probably heard of it as a cytokine storm. This storm makes the blood vessels leaky, so fluid just pours out into the tissues, and the patient's blood volume plummets. This leads to the final, fatal step. The microcirculation fails, starving the cells of oxygen. It's this cascade of failure, right down to the mitochondria, the cell's powerhouses, just giving up.
And now we get to the absolute core of the question. How does all of this physiological chaos mess with drug handling? The best way to answer this systematically is to use that classic framework we all know, 8ME. Absorption, distribution, metabolism, and elimination. So let's start with A for absorption. Look, in a septic patient, you just can't rely on getting drugs into the system through the gut or muscle or skin. The perfusion is just too poor and unpredictable. This is why getting good IV access isn't just a matter of convenience, it's absolutely essential for reliable drug delivery.
All right, so even when you get the drug into the bloodstream, where it actually goes, its distribution, is completely turned on its head. Those leaky capillaries let water-soluble drugs just escape into the tissues. At the same time, you've got changes in blood proteins and pH that can dramatically alter how much free, active drug is actually available to do its job.
Now, here's a really key distinction, one that examiners love to see you make. For hydrophilic or water-loving drugs like gentamicin, the volume of distribution gets way bigger because the drug follows all that leaking fluid out into the tissues. But for lipophilic or fat-loving drugs like propofol, it's actually the opposite, at least at first. Blood gets shunted away from fat and peripheral tissues, which concentrates the drug in the central circulation, and that has some major implications. Moving on to M for metabolism. In sepsis, the liver takes a big hit. Reduced blood flow can seriously impair that cytochrome P450 enzyme system. And what does that mean? It means drugs that rely on the liver to be broken down can just hang around and accumulate, sometimes reaching toxic levels really fast. And it's a very similar story for E, elimination. Acute kidney injury is incredibly common in sepsis. So for drugs that are cleared by the kidneys, they can build up to dangerous levels simply because they have nowhere to go.
Okay, so that's a lot of theory. Let's make it real. Let's apply all this to a drug we use every single day, propofol. Using a specific example like this in your answer is a fantastic way to show that you can connect the basic science to actual clinical practice. So let's think this through for propofol. You have low albumin, which means more free, active drug floating around. You have a smaller initial volume of distribution, which means a higher concentration in the blood. What's the result? A standard dose can cause profound, life-threatening hypotension. And here's the paradox. Because of poor cardiac output, it might actually take longer for the patient to get sleepy. It's a dangerous combination.
All right, final part. Let's tackle a really common clinical problem. Why is it that in prolonged sepsis, you find yourself having to crank up the doses of drugs like noradrenaline higher and higher just to maintain the patient's blood pressure?
Well, there's a specific term for this phenomenon. It's called tachyphylaxis, and honestly, just naming this concept can score you a mark. But for the big points, you need to explain why it's happening.
So what's going on under the hood? Well, it's a few things at once. The body's adrenergic receptors, the targets for these drugs, they just get overwhelmed and start to disappear. At the same time, the body starts producing its own vasodilators, which actively fight against the drug you're giving. Throw in the acidic environment of sepsis, and you have a system that is fundamentally resistant to the drug's effect.
So After all of that, what's the critical takeaway? For your exams, and more importantly, for your patients, it all boils down to one single crucial principle.
This quote really says it all. The effect of sepsis is hard to predict. You cannot rely on standard doses or cookbook medicine. Variability is the rule, not the exception. And that means you have to be vigilant, you have to titrate every single drug to its effect, and you have to constantly reassess.
Ultimately, this isn't just about memorizing facts to pass an exam. It's about fundamentally shifting your mindset at the bedside. It's moving away from standard doses and towards a constant, careful process of titration and observation. That mindfulness is what keeps these incredibly vulnerable patients safe.